Hi guys, how are you? Good afternoon, and I hope I did not make you wait too long. I was sure that 12:30 I'll start, but some glitches here and there will keep coming sometimes, and I hope I'm pardoned for these 5 minutes. I hope you all did a very good exam, and the questions this time, it was looking as if they're going to ask you the tough types because last NEET exam was really tough. This time they asked you questions which are matter of fact. Some of them were good, some of them were tough, but then none of them were unexpected and none of them were like crazily tough. So you didn't have to stretch your imagination too much, but yes, your clinical sense is always tested nowadays, and please be very sure that try to understand situations than just mugging up facts. All right, try to understand situations. So like always, all the recall sessions, I'm just giving a disclaimer, like the questions discussed in this PPD are recall based, and the motive of this live session is to get the actual questions asked in the team, asked in the exam. So I'll be hoping that my team will get all the correct questions and the correct choices as we discuss this, and then later this will be included in the app. Right, guys, we'll start with the first MCQ. Are we all on? I think not many have joined so far, but then I'm sure. Hi, Dr. Lulu, and others, whoever is waiting, please join in as fast as you can. Please send messages to your friends, and we'll start with the first question. So this was that one question which I was discussing just a day before when we were having our recall sessions, and I was telling you that this has found a favor with the NEET and also with the INI-CET exam, the obstetric score. So when we write this G2, P2 and all this, this is known as the obstetric score of a person. And the obstetric score of a person is represented as like the GPLA system, the Grada Para Life Aborta. Now, there's another one which is the GTPLA or AL, either way you can write. So, this only thing is the P. P means parity. P is parity. That is any fetus which is beyond 28 weeks, which has delivered beyond 28 weeks, which is known as viable. So if a mother delivers a baby after 28 weeks, it's called a viable baby. And if she delivers the baby after 28 weeks, we say that she has attained parity once. And gravida is a state of being pregnant. Gravida is she is pregnant, then only we shall use the term gravida. Suppose there's a woman who is 65 and she has 3 children, we'll never call her G4P3L3. Please don't put that G because she's not pregnant, and at 65 she cannot be pregnant. So if she's 65 and she has 3 living children, we say para 3 like 3. We don't use the term G. Now, if she's 25 and she's got 2 children, she's delivered 2 children and she's got 2 children, still we don't put a G. We say para 2 live 2. You don't have to put a G till she is pregnant. Now, you don't even have to write a G0. A lot of you have a misconception that we can write a G0 if she's not pregnant. No, you don't have to do that. Just write para 2 live 2 if she's got 2 live children. That's it. So now this question. A 25-year-old pregnant lady came for a regular visit. She delivered twins 4 years ago. Calculate the gravida and para. I think the language would have been different, but very simple. So we will always, when we're using this formula, we go from the reverse. We always start from abortion. So we don't have any information that she had an abortion. So A0. And how many live children? She's delivered twins. I assume they're living. So live 2. And she's delivered once. If she's delivered once, she attained parity only once. So in that act of delivery, she has delivered 2 children. So parity does not become 2. Parity is only once. Once she has delivered 2 children. Suppose she delivered triplets last time. So then would say para 1 live 3. This patient, she delivered twins. So we'll say para 1 live 2. All right. So now she's pregnant again. She came for a regular pregnant lady. So she's come for a regular visit. We know that she's pregnant. So she's now gravida 2. So para gravida 2, para 1, live 2. So these are a little incomplete formulas which have been sent me, but I'm sure that you'll be, what are you guys writing? G2P1. Yeah, G2P1 is what is correct in this example, but I'm sure it has to be G2P1 L2. This is how you'll have to represent. So live, how many? If they are live, 3 children, 4 children, you'll have to write 3 or 4. but you don't have to increase the parity because of the number of live children. If the patient has delivered once and she delivered 3 children, it will be still para 1 like 3. All right. So now there's another thing about the other system which is used, and that is the GTPAL system. So if a baby is delivered after 28 weeks, we say the baby is viable. But after 28 weeks, if it delivers at suppose 32 weeks, we say it is preterm. Suppose the baby delivers at 38 weeks, we say it is term. So this other formula, this one here, this is just that the para has been split into term and preterm. That's all. The GTPAL system, which even Williams mentioned that it is used in some localities. It is not used everywhere. It is not the standard one. And I'm sure all of you have seen this exam, who have written this exam, you've seen that even in the exam, they asked you GPLA system, and they've not asked you the GTPAL system. All right. So please go ahead and remember the GPLA system always. Chali, we spent a rather unusual amount of time on this one. Let's move on. Why am I asking you? Because see, this is something very simple, and they keep asking you the exam. So don't miss out on this. Any doubts you have on this? I don't think so. Yeah, this is rather quiet. Okay, let's move on. A prima grada delivered a baby girl. She's a known case of bronchial asthma. There is profuse bleeding after delivery. Which of the following drugs should not be used? Should not be used to control the bleeding. So yes, we are thinking in terms of managing a postpartum hemorrhage, and I can see 3 of these are prostaglandins and one is oxytocin. So definitely we will give oxytocin, and we will have to give some good drugs like prostaglandins if the bleeding doesn't stop. But the problem is that she is an asthmatic. Now, there's something about the prostaglandins which you should be reading with your pharmacology friends, but please remember that most prostaglandins are vasodilators, the ones which we use in obstetrics. Most are vasodilators. Okay, but yes, carboprost, the PG, excuse me. Yes, carboprost. Just a minute. Carboprost, which is PGF2 alpha. This is a bronchoconstrictor. Rest, misoprostol and even dinoproston, these are bronchodilators. So oxytocin, of course, is given. And latanoprost is one of the, I don't know whether this was a choice, but yes, this is one of the congeners of carboprost. Latanoprost is basically PGF2 alpha again, but it's one of the congeners which is used in I think ophthalmic use. It's used in ophthal for the glaucoma. So latanoprost, I don't know much. I also saw it on the internet when I saw the choice, because I have not used this drug at all. So carboprost, yes, is PGF2 alpha, and I will not be using. So amongst these two, I'm sure the choices would have been different. But remember, carboprost we will not use. So just to summarize that, bronchodilator action we have with prostaglandin E2 and prostaglandin E1. E1, of course, is misoprostol. This is misoprostol, and E2 is dinoprostone. So the answer is carboprost. All right. So prostaglandin F2 alpha is a bronchoconstrictor. Okay, chale. So what are you guys writing now? Let's see. Dinoproston tha. All right. So we'll change this latanoprost to dinoproston. Yes, it makes sense. It should be dinoprost. So we'll keep this when we are writing the final exam, final list of things which we have to discuss. Okay, check. Let's move on and see the next one. In cancer cervix, neoadjuvant therapy is given along with. Now, I don't know what they're trying to ask, because the neoadjuvant is fairly simple meaning that when we give anything before surgery, like I'm planning a surgery, but before that I do something. I can give before the surgery, I can give chemotherapy, I can give a radiotherapy, I can also give a hormonal therapy sometimes. Like suppose it's a case of endometrium, I can give a hormonal therapy to get the tumor a little contained. So chemotherapy, radiotherapy, hormone therapy, all of this can be given neoadjuvant, that is before the surgery. So anything before the surgery is neoadjuvant. Now, in these choices, I see only one choice, and that is choice number D, before a radical surgery. Other choices are along with surgery, along with radiotherapy, and after radical surgery. Doesn't make sense. None of these are correct. There's only one which is before, and that is before radical surgery. There is only one choice. This is choice D. So that is the answer. Neoadjuvant means before. Adjuvant means after the surgery or the whatever procedure you've done. If you give, that is known as adjuvant chemotherapy or adjuvant radiotherapy for that matter. So let's see what choices you guys are giving me. Before, okay, fine. Okay, I'm sure this is a fairly simple. If this was, will you please tell me, those who are listening to me, will you please tell me that choices were these or there was something different asked? Can you help me with this? If there's something else asked about this question. I think they just wanted to find out if you know that what is the meaning of neoadjuvant. I think I'm quite certain that they wanted to ask you just that. Okay, most of you agree. Some responses come. Let's move on. 24-year-old lady presents with 36 weeks plus 6 days of gestation. On examination, fetus was in a transverse lie with adequate LICA. Placenta is normal in position. Weight of the baby is 2.3. Some people said, sir, it was 2.8. Both the weights are fine. Okay, 2.3, 2.8 for a woman who is 24 years, average height. This is not excessive weight. What is the next step in management? So they're trying to tell you the fetus was in transverse lie. So if the fetus is in transverse lie, what you can do? Look, when there is a transverse lie, when the fetus is in transverse lie like this, then we call it a shoulder. See, the shoulder is in the lower segment. So it is lie is transverse, but the presentation is shoulder presentation. So please remember that shoulder presentation is the presentation and the lie in this is transverse lie. So first get this correct. Now, what can be done when the pregnancy is 36 weeks plus 6 days? So when a patient is 36 plus 6, she's not in labor. And don't say cesarean section, please. Obstetrics is to understand that we are trying to continue pregnancy safely and deliver that pregnancy normally. Obstetrics means normal vaginal delivery. Yes, if there's a problem, then obstetrics also means that you are smart enough to do a cesarean section at any given moment. So obstetrics does not mean doing a cesarean for every situation which is confronted. So please, this patient is at 36 weeks. She's not in labor. So you do not have to first say cesarean section. That itself is a wrong answer. See, what have you guys written? Expectant management. Expectant management. No, I'm not. Yes, I'm not going to do expectant management. No, they've asked you this question with a purpose that we are teaching you correct or not. At least that much we should know. And then patient was the option was expectant management, expectant. Take my expectant management. I want to. Internal portalic was not given, sir. It was expectant. What is the ideal management of baby? 2.8. Ideal management. Ideal management. Okay, fine. So internal portalic version was not there. My team who is watching this, please, this choice doesn't have to be there. And external cephalic version, emergency cesarean or vacuum delivery. There's another option was expectant. Expectant means leave the transverse lie alone at 36 plus 6. Now, if it is 36 plus 6, then one thing you must understand. The liquor of a patient moves like this. At 32 weeks or 34 weeks, it is maximum 1000 ml. And at 40 weeks, it is around 600 ml. So if suppose there is a transverse lie here, then as the pregnancy, suppose it is 28 weeks, and there's a transverse lie. As the pregnancy advances, then it may correct and become a cephalic. Now, after the liquor reduces, see, 36 weeks, it is only 800 ml. So 36 plus 6 will be still lesser. Now, at around 36 plus 6, that is 1 day less of 37. At term, if it is still transverse lie, the chances of it becoming spontaneously corrected to cephalic is very, very rare. So please understand, expectant management won't be the best answer, number one. Number two, you know, they're asking you this question only for one purpose, that when the liquor is reducing, please understand, when the liquor is now reducing, it is 36 weeks, the liquor is now less. This is the time we can turn a baby and make a favorable cephalic presentation rather. So yes, we can turn this baby, okay? We can turn this baby this way and get the head in the lower segment. So we know that this is a much better delivery to happen. So external cephalic version can be done. External cephalic version can be done around 36 weeks in a primigravida, 36 weeks in a primigravida, and 37 weeks in a multigravida. That's why they gave this range. Why we can't do at 28 weeks? Because if you turn the baby at 28 weeks, 28 or 30 weeks, the baby is small and the liquor is only increasing. So if you turn the baby, then the baby will probably go back to his favored position. So you turn the baby, he may return back to the transverse lie. So any transverse lie or any breach, if you want to do a turning, a version, what is that? External cephalic version. External cephalic version can be done at 36 weeks in a primigravida and at 37 weeks in a multigravida. So yes, this MCQ is given only for the purpose of knowing whether you know about version. See this here? We are trying to do a version here. Version means turning the baby in a favorable position. It is done through the abdominal wall, and one radiologist or a gynecologist holding an ultrasound probe on the tummy of the mother, and with your hands, you're slowly turning it. After turning the baby, you will check for the fetal heart rate. If there's any bradycardia or persistent, transient bradycardia is still okay. Persistent bradycardia, you have to return the baby back to the original position. Or if it is too bad a bradycardia, you may have to do an emergency cesarean section also. So that's why external cephalic version is done only in an institute. And if there's a fetal distress or even an abruption where the baby is suddenly very sick, you should have a 24-hour cesarean section option available. So don't do this external cephalic version in a ultrasound center where somebody is doing an ultrasound in a market, and there suddenly somebody does an external cephalic version and the heart rate goes low. By the time you reach a hospital, the baby might be dead. So do it only in an institutional setup, and only a gynecologist does it, not a radiologist. Radiologist will help you with the ultrasound, but not with the version. All right. So elective CS was there. So elective CS was there. I will not do the elective CS. So elective CS is an option. Elective CS, if the patient was given, the history given to you was 38 weeks, 38 plus 6, 39 plus 6 in transverse lie, I would have definitely said go ahead and do a cesarean, because at 38, 39 weeks, if you try to do the version, the uterus is irritable and you'll not be successful. So by the book, if you say 36, 37 weeks, we can do the versions. So we have done versions even at 39 weeks, and it has worked. In the present hospital where I'm working, it has worked. But we cannot say that as a recommendation for you guys. So best is 36 to 37 weeks, and that is primary and multis, where you can do a version, whether it's transverse lie or breach. Okay, I will not do a cesarean for this. I'm so sorry. Those who answered cesarean section, emergency cesarean section, definitely not. And elective cesarean, definitely not. They've given you this information only for this. Why did they write adequate liker? Why did they write 36 weeks? Just because you should know that a transverse lie is not in labor. You can turn the baby and make him cephalic. They can ask you for breach also this way. What if it would have been if the question was liquor was excess? If the liquor is too much, then it is very difficult to do a version, because if it is polyhydramnios, then you cannot hold the baby. And then trying to hold the baby and pressing, then you can probably cause a rupture of membranes. So all those precautions, of course, we will know. But this was an ideal situation for a version. Okay. All right, I think I'll consider on this, some chat going on. Okay, so I hope you understood the importance of versions. Now, this is the way we do a version. Let's see the next question. A pregnant woman visits the OPD, 2 months of amenorrhea. She was found to be 7 weeks pregnant and she was having anemia. On investigations, hemoglobin was 9 grams/%. Iron supplementation has to be taken from which week? I'm very sure there is no discussion. The only drugs which can be safely given safely given in the first trimester? It is folic acid and thyroid supplementation, thyroxine. So these are the category A drugs. Category A drugs can be safely given in the first trimester, and these are folic acid and thyroxine. There are no harm mentioned about these drugs, safest. Now, any multivitamin, especially things like vitamin A and even iron, if given improperly, they can cause side effects. They can cause harm to the mother, definitely to the fetus in the first trimester. So we always say vitamin A, we don't give supplementation pregnancy. Only the beta carotenoids can be given. So many overdoses of multivitamins and minerals have been reported. So anything you want to give after the organogenesis complete, that is 12 weeks. So after 12 weeks, after first 3 months, that is the best answer always. So 8 to 10 weeks, not enough. From 20 weeks, too late. And from 14 weeks, so 10 to 12 weeks. 10 to 12 weeks also not happy. So was 14 weeks the, in this ABCD, whatever choices has been given, 14 weeks I have to mark. But best would have been 12 weeks. If there was a choice like this, I would have marked that. So what were the choices? Let's see what you guys are telling me. Okay. Himanshu Rao, we can run a base, we can do ECV for breach and we can do it for transfer line also. Krishna Kadam, thank you so much. 8 to 10 weeks, community medicine teacher. Anything you want to give in pregnancy, please give it after 12 weeks. 14 weeks was there. I have marked 10 to 12 weeks. Anil Jain. Same choices. Okay, fine. Now, anemia management and management, Goku, I can just tell you, Anemia Mukt Bharat. Please, Anemia Mukt Bharat, go and see the website. Anemia Mukt Bharat, of course, Mukt Bharat, the present government wanted to do it for something else. But I like the slogan, Anemia Mukt Bharat, more than the political slogan. So, of course, this is not a political session. I'm just trying to say Anemia Mukt Bharat is a good initiative taken by the present government. And it is, you just put that on the internet, you get all the recommendations, what they're trying to say for children and for pregnant mothers. And now the gist of that is that if a mother is anemic and she comes in the first, second, third trimester, depending on that, we can make a decision. But the punchline of this is that, see, best answer is more than 12 weeks, but that was not in the choice. I'm just saying more than 12 weeks, if it was given, that is the best. So 14 weeks is still fine. Why we say 14 weeks? Because first trimester is 14 weeks by most of the books. Only in India, we say first trimester is 12 weeks. Most books will say first trimester is 14 weeks and next is 14 to 28 weeks, which we say 14 to 28. Most books will say till 24 because viability starts after 24 weeks in their country. So yes, we say first to 12 weeks, 12 to 28 weeks, and 28 weeks to delivery are the 3 trimesters. And after 14 weeks is the second trimester. By some books, we say after 12 weeks. So go ahead and mark after 14 weeks if these were the choices. Everybody's saying these were the choices. Okay. Now, when we say anemia, so if it is nearing term, if the pregnancy is nearing term, there is a problem of giving just tablets, because if we give oral tablets will increases iron by 1 gram % in roughly 2 weeks, 2 to 3 weeks. Don't say that if you give iron tablets and give very high dose iron tablets, within 2 days, 1 gram hemoglobin will increase. No, there's nothing which can increase hemoglobin so far if you give it orally. So oral tablets increase iron by 1 gram in 2 to 2.5 weeks, some books will say. Now, injectable iron, suppose injectable iron is given, the only indication, injectable, that is IM or IV, only indication of this is intolerance or malabsorption. Intolerance or malabsorption is the only indication of giving a patient injectable iron. Okay. Do not think that injectable iron will increase the hemoglobin any faster than oral iron. So the rate of rise the rate of increase of hemoglobin is again 2 weeks to 2.5 weeks. Of rate of rise by 1 gram, again by 1 gram hemoglobin is again 2 weeks to 2.5 weeks. So if you give oral, if you give injectable, there is no benefit. Only thing, if a woman is vomiting too much and she's got a malabsorption syndrome, intolerance to iron, then you go ahead and give injectable. That's the indication of injectable iron. So now, nearing term, that's MCQ. Suppose she is 36 weeks and her HB is 7 grams only. So 1 gram will increase in 2 weeks if you give oral. Another, by that time, she'll be 38 weeks, good to deliver, and she'll be only 8 grams. So when it is nearing term, suppose the patient is 34 weeks, 35 weeks, and she has severely anemic, then give blood transfusion. Okay, then give blood transfusion. That's the best management of a patient who's nearing term and having anemia. All right. So I guess that's what is important. Of course, one more precaution. When giving oral, don't give IM. When giving IM, don't give oral. When giving IM or IV, iron supplementation, stop oral iron therapy. Now, why should you stop the oral iron therapy? Why should you stop the oral iron therapy when you're giving injectable iron? Because the absorption is from the same gut receptors. Okay, let me try and show that to you. See, if you give oral, suppose I'm trying to make the gut here, and if you're giving oral iron here, then the gut receptors here, these gut receptors only will absorb the iron. Okay. Now, suppose you give it into the muscle. This, suppose the gluteus maximus, and in this, you're giving the injectable iron. Now, the injectable iron, suppose you give it here. This will also go through the circulation and reach this receptor only for absorption. So, if you give oral iron, this oral iron will saturate these receptors. These receptors will be saturated, Fe saturated. So if they're saturated, then the injectable iron which you're giving won't be having receptors to absorb this iron. So this injectable, suppose you're giving oral iron, these gut receptors are saturated and the injectable iron will be extra. So that the patient will go into iron overload. It will all deposit in the liver. Right? So I shall I'm very sure that you will not be using this oral and injectable together. Give only either of these. All right? Sure. By the way, how much hemoglobin increased by one blood transfusion? One whole blood increases HB by 0.8 gram%. I know roughly we say 1 gram%. So one whole blood increases the HB only by 0.8 to 0.9. I mean, if the donor is 18 grams hemoglobin or 16 grams hemoglobin, maybe 1 gram will increase. So don't say one whole blood increases 1 gram, roughly 0.8. 0.7, some books say 0.7 to 0.8. Now, what about one packed RBC bag? You're just giving concentrated RBCs. You're not giving the whole blood. You're giving concentrated RBCs. Then how much will the hemoglobin increase? Yes? Let's see what you guys are answering. I'm saying if you give concentrated RBC, one packed RBC, little less than 1. Yeah, most of you KK, MA, and Fox, whatever. Interesting names, man, you guys. 4.5. 1 to 1.5. No, guys. See, it's very simple logic that if you have one bag of whole blood, this is whole blood, and this is plasma in the bag. So when you give this much, it'll be 1 gram% increase. If you give this, there'll be 1 gram% increase. But if you take out the plasma, you take out the plasma, you're still giving the same amount of RBCs. So it will be still 1 gram only if you take out the plasma. So yes, that's what we do. Please, whenever you have time, read about blood banking, blood transfusion therapy or blood banking, blood transfusion therapy or blood banking, whatever you feel is a better way to look at the internet, or you have your books. Please read about blood banking and blood transfusion therapy. There is hardly any indication of whole blood. Like somebody has a volume replacement requirement, somebody has got an injury, and then you want to replace the volume. That's the time when you're going to give whole blood. Okay. Otherwise, whole blood, hardly any indication there. For anemia, we'll give RBCs, packed RBCs. And if a person has a clotting problem, then I'll give fresh frozen plasma, or I'll give a crash precipitate, or if there's a platelet deficiency, I'll give the frozen platelets, the prepared platelets. So platelets will be given for ITP, and of course, the platelets are given for dengue, so many other problems. So specific therapy, you should know specific therapy. Whole blood has almost no place in blood transfusion apart from volume replacement or acute replacement. Otherwise, we'll always give appropriate therapy. All right. So blood banking, please read about it. Okay. Let's move on to another question. A 30-year-old patient who is on infertility treatment with human menopausal gonadotropin. Human menopausal gonadotropin has 75 international units of FSH and 75 international units of LH. And this human menopausal gonadotropin is made from the menopausal urine. Women who are menopausal, they have high amount of LH and FSH, because all of you know very well, the brain is always young, the ovaries get old with age. So ovaries are old, so ovaries are not making estrogens and progesterones. So when estrogen and progesterones are not there, so the brain will go on stimulating the ovary to do that, to make estrogens and progesterones. But that does not happen. So what is the result of it? LH and FSH is very high in the urine of the woman because it's high in the circulation, and LH and FSH will come out in the urine. So we take the urine of these women, old women. Yeah, all you have to do is give big boxes to these ladies. Old ladies, put a box in front of a house, fill some in your whole lane, give some 40 boxes to all these old ladies, and they fill it up and give it to you. Take it to your factory and fractionate the FSH and LH from this urine of old women. And this urine of old women, when we give this LH and FSH, we fractionate them and make into powders and make these small vials, which are given for infertility ladies, for these infertile ladies for ovulation induction. You know how much we sell this for? Around 1,200 rupees for 150 milligrams. That's the kind of money which is involved in vitro fertilization. So that's why this menopausal gonadotropin is made from the urine of old women. Or we can also make it recombinant. Recombinant FSH and LH is much more expensive. So I just thought I'll tell you what you mean by HMG. That is, from the human menopausal urine, you get this LH and FSH. Now this LH and FSH we are giving it to make more eggs. We want to do IVF. So 30-year-old patient who was in fertility treatment with HMG, she developed abdominal pain and dyspnea. What is the condition? So I'm very sure there was more information about this, but yes, they're asking you about ovarian hyperstimulation syndrome, because many eggs are recruited by HMG and FSH. So when more eggs are recruited, then the abdomen will get distended by ascites. Why? Because OHSS will increase estrogen plus the injection HCG, which is given. These two will increase the vascular endothelial growth factor, and this in turn increases the vascular permeability. So increase vascular endothelial growth factor, and that is going to increase the vascular permeability. And when the vascular permeability increases, fluids will move out of the intravascular compartment, and the fluid will accumulate in the ascites in the pleural area to cause pleural effusion, and it can cause pericardial effusion, edema of the body. Can even cause death of the patient. So this is the distension of the abdomen, and because the abdomen getting too distended and the pleura getting filled up with fluid, so lung cannot distend. Lung cannot distend in the chest because of the pleural effusion. It cannot go down. It cannot expand downwards because of the ascites. So there is respiratory distress. So that is dyspnea. And abdominal pain because of the distension of the abdomen. And the ovaries become very big. So all of this is straight away ovarian hyperstimulation syndrome. So when do we say it is ovarian hyperstimulation? When anything more than 20 eggs are ready. Anything more than 20 eggs. Because in IVF, how many eggs you want? We want around 6 to 15 eggs. We want 6 to 15 eggs. Ideal number for IVF. Rough, anything between 6 to 15. If it goes more than 15, it is too much. And definitely more than 20, that is more than 20 eggs, then each egg is around 150 to 200 picograms. So 150 also, if you take 200 picograms, so 20 will make around 4,000 picograms. Okay. So 4,000 picograms for 20 eggs. So why I have with this figure of 20 eggs? Because it is 4,000 picograms for 20. So anything more than 3,500 picograms, that is going to cause the problem. So I told you the high estrogen, that is more than 3,500 picograms, along with the HCG given for the maturity of the eggs. This is going to make the woman have increased vascular endothelial growth factor. This is the one which we've discussed. Okay. Okay, I think we'll move on. Of the following surgeries posted in the OT, all of these can be done by hysteroscope, except I think was there some modification to this question? Which of this can be done hysteroscopically, which cannot be done hysteroscopically? I think something like that was the MCQ. Anybody with a suggestion to this? I think it was a fairly straightforward question. Same question, all right. So yes, Escherman syndrome, best diagnosis is by hysteroscope, and the treatment is called hysteroscopic adhesiolysis. So Escherman syndrome, we do hysteroscopic adhesiolysis. Now, septal resection can be done. Yes, one of the classical uses of hysteroscopy is to do a septal resection. Subserous myoma. Now, subserous myoma is not in the hysteroscopy range of doing things. Tubal ligation, yes, I'll tell you. So, subserous and submucous, that's the difference. In a hurry, you would have probably marked it wrong. This is subserous myoma, and the blue one here is the submucosal myoma. So, subserosal. Why? When we are putting a hysteroscope here, with the hysteroscope, I'm doing a removal of the fibroid. So if it is inside the uterus, the SM, submucosal one, that I can remove by the submucosal myoma can be removed by a hysteroscope. Subserosal cannot be removed. Yes, if you have a laparoscope, then you can remove a subserosal. But for this, you cannot remove. So yes, subserosal myoma cannot be removed. So answer to this question is C. Now, how can you do a tubal ligation? Now, that is what is confusing to a lot of you. So it is not called tubal ligation. It is called blocking the tubes by the Assure coil. So yes, Assure coil came as MCQ some time back. Now they're asking you a related information MCQ to that one. So Assure coil is put like this into the fallopian tube. Here, like this, it's put into the fallopian tube. And this Assure coil, which is made up of nitinol alloy, nickel titanium alloy. This is going to cause fibrosis. So yes, this is done. Assure coil is inserted hysteroscopically. So what were the choices you had? question is wrong. Septal dissection not in the option. What can be done by hysteroscopy? Narrow escape, but Glatzer. Okay, best done by hysteroscopy. Okay, what are the choices? Okay, all except. Okay, fine. Anyway, you know that tubal ligation can be done. Assure coil, fine. And subserous mama cannot be done. So tell me. Cervical polyp, yes, cervical polyp. Cervical polyp, that also can be taken out hysteroscopically. Yes, we can. So see this is the FIGO classification. And when we're doing a hysteroscopic procedure, the hysteroscope is here. So hysteroscopic, for hysteroscopy, the type of fibroid which can we take out is 1 and 0. Okay, let me write it properly. By hysteroscopy, we can take out the type 0 and type 1, maybe type 2, but requires good clinical skills, surgical skills. Now, by hysteroscope, we can take out type 0, type 1, maybe type 2. Now, by laparoscope, which one can you take out? By laparoscopy, you can take out a type 6 or a type 7, but maybe also type 5. So easiest is type 5, easiest is type 6 and type 7, and type 1 and type 2. Now for laparoscopy, a little difficult would be type 5 and even type 4 we have taken out, but they are more difficult. And by hysteroscopically, type 0 and type 1 we can take out, but type 2 is more difficult. Now, when we are doing polyp, the polyp is actually here. See, submucosal polyp is actually here. Cervical polyp. Polyp means here. It can be here or it can be here. So cervical polyp, yes, can be taken out hysteroscopically. So yes, this is the forum where I'm going to get the choices properly. And all of you are saying that choices didn't have septum. Best done by hysteroscopy. Cervical polyp, okay. Cervical polyp, Eschmann, submucous, subserous myoma, tubal ligation. So, no, boy, I don't know if this was the question. Best done means I will go with the Eschmann syndrome. Of course, cervical polyp and this one tubal ligation also can be done. But I don't know. Then it doesn't make much sense, the choice which you're giving me. All right, question is different. Fine. Chalo, jo bhi hai. At least we discuss something. Okay, Venkatesh Prabhu and Anil. So if that is the question, then I'll go. The best would be the best thing. Yes, cervical polyp can be taken out with a small forceps also. And tubal ligation is better. We can do it by other procedures. So best done by hysteroscopy. If they're really asking, tubal ligation can be done by laparoscopy also, by open also. So if that kind of logic is there in the question, and that's the question which all of you are saying is asked, then I'll go and say hysteroscopic heterolysis for Eschmann syndrome. Then that would be the best question. चलिए आगे बढ़ते हैं. A 16-year-old girl with primary amenorrhea presents with cyclical abdominal pain with a suprapubic bulge. On examination, there is swelling along the entire vagina. What is the most likely cause? So yes, this was that straightforward question which they wanted you to answer immediately. So uterus is making blood, so is the vagina which is collecting it, but the hymen is imperforate. So the complete vagina complete uterus. So that's the information. Cyclical abdominal pain with suprapubic bulge. On examination, there is swelling along the entire vagina, which is the more likely diagnosis. If the entire vagina is swollen, how do you actually make out entire vagina is swollen? by a per rectal examination. See, you're doing a per rectal examination like this. So there's the bladder in front, abdominal wall, there's the sacrum. So if this is blocked, see, if this is blocked, if this vagina is blocked, this is a imperfect hymen. If the vagina is blocked, then there'll be collection of blood in the vagina, which is known as a hematocolpus. Now, when you do a per vaginal examination here, suppose you do a per vaginal examination here, you'll see the full vagina is having collection. When the full vagina is having collection, then we say it is a imperforate hymen. So answer to this is imperforate hymen. Now, be very careful. Sometimes, see this, I think I was taking classes some 2-3 places recently where I've taught you the difference. Now, if this was at this level, if there was a transverse vaginal septum and the hymen is having no problem, suppose there's a transverse vaginal septum like this. In a transverse vaginal septum like this, the blood will not fill up the whole vagina. The complete vagina will not be filled up and the blood will be collected here. So when the whole vaginal length is full of blood, then we say hematocolpus, which is seen in imperforate hymen. When only partly it is there, then it would be a transverse vaginal septum. So yes, the answer definitely is imperforate hymen. That's fine. I think this is more or less understood. So these are the defects. This is the Mullerian defects, which I thought I'll give you the classification here. This is known as the Eschere classification. The Eschere, the European Society for Human Reproduction and Embryology, one of the favorite conferences which I go to attend, the Eschere conferences in Europe. And these are very, there's a lot of enthralling discussions which come out of these conferences. It was one of these conferences which I went in 2018, the conference in Barcelona. And that conference, they were telling us about the use of letrozole as the preferred drug for PCOS. And after that, the recommendations came out, and the whole world now follows that letrozole is the preferred drug for ovulation induction as compared to clomiphene citrate. Letrozole is preferred. So that was Eschere conference when it was, advised that this should not be the preferred drug. Now, Eschere classification of the defects. The first is the U0, which is the normal uterus. I don't know whether you can read this. I'm writing this. U0 to U6 is there. This is U6. So U0 is the normal uterus, and U1 is dysmorphic uterus, like the T-shaped uterus because of diethylstilbestrol ingestion during pregnancy by the mother. So that's the T-shaped uterus. And then U2 is the septate uterus, the one which you're showing here, partial septate or total septate. And U3 is the bicorporal or the bicoordinate uterus. And U4 is the hemiuterus, part of the uterus there, other part is not there. And B5 is a plastic uterus. Everything is absent, and there is only one small rudimentary horn, nothing else is seen. So that is aplasia. Total Mullerian agenesis also comes here. Okay, total Mullerian agenesis also comes in this aplasia. And U6 is the unclassified types. So I don't know whether this is going to come in your exams, but in the near future, because this is slightly tough. But they have asked you that which type of defect is the septal defect. So it's a Mullerian defect, and it is the U2 type of defect of the Eschere classification. By the way, which is the most common Mullerian defect? Come, let's see if you can tell me this answer. Let's see, guys. I'll wait for you. Which is the most common Mullerian defect? Yes, that's MCQ. All right. Most of you said it correctly. Septate uterus is far more common. Okay, chalo. Now, a 23-year-old lady brought by her mother-in-law to the OPD with the complaint that she is not able to conceive even after 6 months of cohabitation, which is the next best step of management. Please tell her to come after 6 months. Please, this is the easiest question which came in this exam. Please, infertility is defined only after 1 year of cohabitation. 1 year of cohab, then only we say it is infertility. Whether it's primary infertility, that means she's never been pregnant, or whether it is secondary infertility. Either way, it is 1 year. Primary means never pregnant. Secondary means she had a delivery, she has a baby, now she's not conceiving. Or she had a ectopic. She had a ectopic, not conceiving now. Or she had an abortion, not conceiving now. Any pregnancy-related event, even if it's a molar pregnancy last time and now she's not conceiving, it is still secondary infertility. And for secondary infertility also, it is 1 year. Please, I don't know, somewhere I saw that somebody said that if it is a woman is less than 27, it is 1 year. After 27, since she's getting older, infertility is 6 months. I hope you're not following that. Okay. Anytime it is 1 year. Now, what do you do? Tell the mother-in-law to be patient. Okay, this is what happens. Even when I know some of you remember that when I take your live classes, I crack this as a joke, and I hope I'm not supposed to do that online, and this will be recorded. So yes, every time these women come, I keep telling them that please come after 1 year. You're not supposed to come for treatment and investigation. They're all very expensive, because 90% will conceive. 90% will conceive within 1 year. In fact, 80% will conceive within 6 months of cohabitation. So that's why we say wait for at least 1 year. Okay, so B option was not there. B option was not there. I thought that's the easy answer. Okay, reassurance was the options. Okay, fine. That's just as well. Okay, chalo. Okay, a woman with cervical cancer was recently treated by radical surgery. What is the best advice given to her 14-year-old daughter? By the way, cervical cancer does not have this familial predisposition. You and me know cervical cancer is a lifestyle problem. People who are exposed to too many partners, and partners are exposed to commercial sexual workers. Commercial sexual workers themselves have more association with HPV, association with HIV, HSV, and then early sex and just too much of sex. I'm so sorry. That's how it is. But CA cervix can happen also to monogamous relations. Okay, don't think that it only happens because of that kind of lifestyle which I told you. It can also happen to very dedicated couples, but that is rare type, because HPV is sitting on the body, and with intercourse, the HPV finds its way into the genitalia. But that is rare. Mostly CA cervix is associated with the stories which I told you. Now, what advice you give to the 14-year-old? I don't think that was a very good correlation if this was the exact question, because whatever questions I've given you today, most of you saying that this is what came in the exam. So if this was the question, I don't think they made it properly, because they're talking about CA cervix, then giving something to the baby will prevent the occurrence of CA cervix. This is not congenitally or genetically transmitted to the baby. So to the daughter, I don't think. Okay, that is only the CA endometrium, CA ovary, and CA breast. That has got a familial predisposition. Yes. What advice can you give to a 14-year-old girl to prevent her from having CA cervix later in her sexual life? That would have been an excellent question. What advice you can give to a 14-year-old girl to prevent CA cervix later in her life whenever she gets sexually active? So yes, that is of course to give the HPV vaccine. By the way, I'm not a very big fan of this vaccine. I think I would have conveyed it many times earlier. Dr. Lulu saying that this was indeed the question, and so is Anil and Neeru, and wow. So if this was the question, then we can say HPV vaccine, because see, last year they asked you about this. What are the SAGE guidelines? So this SAGE guidelines is why this 14-year has come, because SAGE guidelines say that all girls 9 to 14 years give at least one shot, or one dose rather, of HPV vaccine. I'm writing for vaccine. So give at least one shot. See, I told you, let me try and tell you that why I'm liking at least this part of the guidelines, SAGE guidelines. What is SAGE, first of all? SAGE is strategic advisory group of experts. This is experts, huh? Strategic Advisory Group of Experts, SAGE, on vaccinations. So Strategic Advisory Group of Experts on Vaccination, the SAGE guidelines says that give at least one injection to all girls 9 to 14 years. So that is not a bad thing to do. Something is better than nothing. Otherwise, if you ask me about Gardasil 9, see, Gardasil 9, a lot of people ask me, sir, can we take the vaccine? A lot of students and a lot of my friends and my relatives and my patients, I don't give this. Seriously, I'm saying this on record because if I don't give this, I'm not saying anything wrong about the vaccine. I'm just saying I'm not very happy with this. Okay, that is okay, because it is preventing only against 9 serotypes, and CS cervix happens with at least 50 serotypes. 50 more serotypes are present. So I'm saying that if I protect only against 9, then those 9 high-risk viruses, okay, fine. Against those common viruses, we are giving a vaccination. But there are another 40, 50 odd serotypes which can cause CS cervix. So it's not a total protection. So don't think, what is the basic meaning of this vaccination? Please see, you miss out on this part. You give the vaccination, there are 3 doses to be given: 0 day, and then the 2nd month, and then the 6th month. You give 3 vaccines, and after giving these 3 vaccines, you tell this woman, keep coming for the pap smear and this screening. Screening procedures continue. We are not stopping the screening after giving this vaccination. So why do we come for screening? Because there's no protection. Why? Because it's only 9 serotypes. Earlier, there was this Gardasil 4, which was only 4 serotypes. Before that, there was Cervix, which was only 2 serotypes. So whenever they made a vaccine, it was not enough. When they said, give these 2, I didn't give. When they said, give these 4, now it's better, I said, no, I will not give. When they said now it is 9, I'm still not convinced, because it can mutate these viruses. And of course, it is not giving a complete protection. So my advice is that have a good, clean lifestyle. You don't get CS cervix. That's my advice to my patients. And if at all, these young girls are given this vaccine, SAGE guidelines, that I wholeheartedly support, because something is better than nothing. At least these 9 to 14 girls, why they give this? Because a lot of these developing and underdeveloped countries, girls are into sexual activity by force. Either they get married, and those men have multiple partners, so they get married at 15, 16, and low socioeconomic status, these people will have more HPV infections likely. So these husbands, they will be getting the virus home, and these young girls will be exposed to this virus as early as 16, 17 years. So give some protection. So I wholeheartedly support this SAGE guideline. But if educated people come to me, I always say that if you have a clean lifestyle, then you don't have a problem with CS cervix. Yes, mostly you will not have. Bad luck can happen, but you're protecting yourself by just a clean lifestyle, monogamous relations, and clean sex life. Anyway, that's what I think, and that's what I tell my patients. And I have not given this vaccine to any of my patients. It's a good, it's a good industry, and people do give it. But I'm telling you what I do. Okay, I'm not advising anything. I'm just advising my students and my listeners that have a clean life. Okay, I'm not going against any companies. Okay. Why? HPV does cause cancers in men. Man, what's wrong with you? It definitely causes Goku. It does cause cancer in men. You know what is? Go and read your go and read your Noakes Gynaecology. You know what is written? What is the recommendation? That when you give this vaccine, you give it to 9 to 45-year-old all women plus all men. People are missing this part. You must give it to all men also. Men are the ones who are putting the HPV vaccine. I'm so sorry. Men are the ones who are putting the HPV into the women, right? So men should also be vaccinated. Yes, they are the ones who will be harboring the HPV. And they can also have cancers. But yes, you know very well that if men keep themselves clean, and yes, circumcision is one of the methods by which men have reduced this incidence of cancers of the penis. All of that is well documented. And yes, it's a very big discussion which we can have. But seriously, the best thing is that have clean lives, and the vaccine actually has to be given to everybody. So that's what is being purported, that the vaccine should be given to everybody. Imagine the kind of finances and the kind of money which will be involved, and how much money the companies stand to gain. But yes, those who can afford it, I say those who can afford it and are like, okay, fine, I'm protected against at least 9 serotypes, go ahead and take it. Okay. But as a academician, I would say that it's not enough yet. I think I would want more protection for my patients. So for the timing, I feel it is not enough. But that's a personal answer, personal choice. We are discussing what you can give for a 14-year-old. Answer is HPV vaccine. Personally, what I feel, I told you openly that having a clean life is better. Sorry. 27-year-old female, I think this is in a slightly small font. I'll read it loud for you guys. A 27-year-old female presents with 2 months of amenorrhea with previous 3 regular cycles. On ultrasound, the left head neck cell mass is seen of 3 in mass of 3 into 2.5 months. I'm so sorry, I should have read this centimeters. Her HCG was 2,800 milli-international units per ml. There is no fetal pole in the uterus, no cardiac activity. What is the next step of management? Okay, once more. A patient is pregnant. She always had regular cycles. So we are very sure of her dates. That's why they've given you this. Previous 3 regular cycles means these are good dates. You know, in obstetrics, we have to know what are good dates and bad dates. So if a person is having 3 regular cycles, then these are good dates. Now we know she's reliable in her menstrual history. Now she's pregnant for around 2 months, and there is a left head neck cell mass of 3 into 2.5 centimeters. Apologies for the mistake. Now there's a mass which is clinically obvious, but the HCG is 2,800 and you cannot see any intrauterine gestation. So this is a mass in the adnexa. HCG is present. Anything HCG, any HCG more than 5 is pregnancy. So she is pregnant. There's a mass in the left adnexa and there is no fetal pole in the uterus and there's no cardiac activity. What is the next step? No cardiac activity in this lesion. There's no fetal pole in the uterus, and there's no cardiac activity in this lesion, which you're seeing. So what are they trying to say? That size 4 centimeters, HCG 5,000 international units, and cardiac activity. We can do medical management. We can do surgical management. Wait, I'll put this here. Give me a moment. I'll put medical management here and surgical management here. So when I'm doing ectopic pregnancy treatment of a small gestational sac, less than 4 centimeters of an unruptured gestational sac. Patient is stable. On the ultrasound, I'm seeing a sac in the fallopian tube. It is not ruptured. That's why you're discussing management. If a patient has a ruptured ectopic, she's in shock. You're an intern, you're running with this patient with your consultant to the OT now. Okay? Ruptured ectopic, treat the shock, do the surgery. I'm talking about an unruptured ectopic pregnancy, which is a very stable pregnancy right now. And the unruptured ectopic pregnancy can be managed surgically or medically based on this information. So if the size of the sac is less than 4, I'll do medical. HCG is less than 5,000, I'll do medical. Cardiac activity cardiac activity is absent. I beg your pardon, cardiac activity is absent. Then I'll do medical management. Now, if the size is more than 4, HCG is more than 5,000 and the cardiac activity is present, then I'll do surgical management. The best surgical management is linear salpingostomy. And the best medical management is methotrexate. Of course, you can also give KCL. Right. So that is the basic information about the management of unruptured ectopic. Ruptured ectopic, treat shock, do surgery. Unruptured, conservative or surgical, depending on conservative means with drugs, or with surgical, depending on these criteria. Now, the question which you have, the size is 3 centimeters into 2.5, so it is less than 4. The HCG is 2,800, so it is less than 5,000. And the cardiac activity is absent. All the three information is given to you. Cardiac activity is absent, HCG is less, and this is size also less. So I can definitely do medical management. No surgery is required. That is also what is asked in this. Now, when I'm doing this conservative management by drugs and not operating, I am mostly giving methotrexate. And methotrexate, the problem is it has side effects. It's a chemotherapeutic drug, anti-cancer drug. And when you give it a high dose, and when you give it multiple doses, it can cause bone marrow depression, it can cause gut shedding and diarrheas, it can cause many problems of intolerance. So it's better we manage by a single dose than multiple dose. There is no criteria. You can see any guidelines, American Royal College, there's no criteria that, okay, if the HCG is 3,000 and less, you give medical, and 3,000 to 5,000, you give medical with more injections of methotrexate. Like that, there's no sure shot criteria. The only criteria for deciding single dose or multiple dose methotrexate is if the initial HCG is low, you give methotrexate one shot. If it is very high, of course, it should be not more than 5,000, then you have to do surgical. If it is higher, then you can give multiple dose. But it is always preferred to give single shot. So that is what is the answer to this single dose of methotrexate injection. All right. So let us see what have you guys answered so far. Adnexal mass. Why ectopic pregnancy? This is an adnexal mass, and the uterus is empty, and she is pregnant. Okay, maybe I can tell you some more bit. What is the other part? If it is 2,800, and if it is not seen in the uterus and something is in the tube or in the adnexal, then it is an ectopic. Because more than 1,500, the discriminatory zone is 1,500 international units. So if the HCG is more than 1,500 international units, then by TVS, we can see a sag either in the uterus or in the fallopian tube. So this is more than the discriminatory zone. It is 2,800. So you should be able to see. It is in the uterus or it's in the tube. You should be able to see. You're not able to see in the uterus. You're seeing something in the adnexa. So it is an ectopic. That's why it's an ectopic. All right. Just around 10 minutes back. Why do you think those 3-4 minutes became extra when I started this? Around 10 minutes before I ran to this place, I'm taking this from the place in my lunch break, because I was for emergency surgery in the OT, and I was doing a laparoscopic management of an unruptured ectopic, but the HCG was 1,800. There was a mass, and there was around 100 ml blood in the pouch of Douglas, but the mass was around 4 centimeters. It was not very high HCG, but it was more than 1,500. I could see a mass, and I was sure that if the mass is big, I have to go ahead and operate it, because blood had started collecting. Although she was very stable, this surgery when I did, it was stable, but I didn't want her to become unstable and then do emergency surgery in the night. So yes, we have this situation seen daily. If the size is more than, if the HCG is more than 1,500, we can see it on the ultrasound. It is seen in this. It is more than 2,800. There was spotting also given, that is agreeable. That is a presentation by ectopic. I've told you spotting was there. Why are you discussing the call when you don't know question? That's the side effect, Krishna. I wish I could help it. Some questions do come to us like that. So, but all the questions, Krishna, they're saying that mostly this was the language. Okay, if this was the language, I think it is all right. We can do a good assessment of what was expected. Perfect will never be there in a recall. You can do any recalls. You can get 1,000 students to write 300, 200 questions. There will be still some mistakes. All right. XC was 2,500. So 2,500, 2,800, chalega. Both of these are more than 1,500, and we can see a sack with this. That's fine. Stardust has spoken to Krishna. Fine. Great. So spotting was given and salpingectomy was given. Salpingectomy I will not do because the size is small and the HCG is less. And we can do methotrexate management. That's all right. It was clearly mentioned there was no cardiac activity. All right, yes. Maybe the language here, which has been recalled by your friends only who've written this exam. So this is how it comes to us. And we have less time. You know, it was a packed schedule where most of the recalls have been done for you. And I was trying to get a place somewhere where I can do the discussion with you. So yes, these are the questions which have been just recalled by friends like you. Okay, I think ectopic pregnancy will always get us discussing a lot. Salpingectomy was there. Okay, fine. I agree. If there was, even if it was in the choice, I will not mark it. I will definitely not mark it. Okay. Right. This is a young woman. I would want her to, probably save the tube rather than doing a salpingectomy. And it was unruptured, so we can save. A woman with 32 weeks of gestation presents with complaints of difficulty in breathing and walking. Her fetal movements are normal. On examination, the abdomen is tense but not tender. Symphysis of fundal height is 41 centimeter. Fetal parts are not easily felt. What is the likely diagnosis? So yes, on examination, abdomen is tense but not tender. Tense but not tender. That means they're trying to tell you that she is not having any acute emergency. There is no abruption. Tenderness means abruption. That's what they're trying to make you think away from a abruption. So 32 weeks of pregnancy. So you can imagine this is the sternum and this is the pubic symphysis. Suppose this is the umbilicus. So the pregnancy is going something like this. This is 32 weeks. So at 32 weeks, you see the pregnancy here. At umbilicus, it is 24 weeks. So this is what you expect at 32 weeks. But this patient's abdominal symphysiofundal height is not 32, it is 41. So it is something like this. It is the whole abdomen is distended and it is stretching, and the symphysiofundal height is 41 centimeters. So it's obvious that this whole abdomen is full of too much of liquor. Okay, so that too much of liquor is causing this distension, causing abdominal distension, and it is pressing the lung. The diaphragm won't be able to move much because this polyhydramnios, because of the big uterus, so the mother cannot breathe too well also. So there is difficulty in breathing and walking, and fetal movements are normal. Baby is fine. It's just polyhydramnios. So fetal parts won't be felt so easily. So that is polyhydramnios. Maternal fetal ascites. So ascites may present like this. Ascites may present like this, but how frequent is maternal and fetal ascites both? You know what is maternal and fetal ascites both? We discussed in the 101 liners. Mirror syndrome is mirror syndrome, but I don't think mirror syndrome is so much rare, and polyhydramnios is much more common. Stillbirth, I don't know, this doesn't make sense as a choice. So if you know the choice, you can tell me, and we'll be following the chat. Okay. Abruption was the option. See, yes. So there is no tenderness. So I will not say abruption. Abruption means abdomen wall will be tender. That's fine. Okay, this is polyhydramnios. Now, what is acute polyhydramnios? Anybody? Fatafat, chalo. Jaldi batao. Acute polyhydramnios. This came in a NEET exam sometime back, many years back. What do you mean by acute polyhydramnios? What's the management of polyhydramnios? Polyhydramnios management is to do controlled tapping up to 1,000 to 1,500 ml of tapping we can do on a daily basis. Yes, some people say on a weekly basis, but yes, we can do a tapping And after tapping, the mother is much relieved. It has a high risk of infection, so we preferably don't do it. If the pregnancy is beyond 34 weeks, lung is mature, we can also take the baby out. But the delivery, if it is normal delivery, it is done by a controlled ARM, controlled ARM. Let the LICA come out slowly. It's a big uterus and suddenly all the LICA goes out. So that LICA suddenly going out will give a negative traction, negative pressure traction on the placenta and cause an abruption. So go very slow. So controlled ARM and delivery. So polyhydramnios, you can tap it, but you can reduce the amniotic fluid by giving indomethacin to the fetus. Indomethacin reduces the fetal urine output. So that will also reduce the amount of LICA. But yes, indomethacin is not given much beyond 32 weeks because it can cause premature closure of the ductus arteriosus. All right. So yes, did you give me the answer, acute polyhydramnios? You're not giving me the answer, guys. Or you don't know. Acute polyhydramnios. It's all right. Acute polyhydramnios is, again, LICA is too much. What is polyhydramnios definition? The amniotic fluid index is more than equal to 25 centimeters, or the amount of LICA is more than equal to 2000 ml. So 2000 ml in the amount of LICA and 25 centimeter amniotic fluid index. Both of these are polyhydramnios. But if this happens before 24 weeks of pregnancy, see, all of you are thinking if there is sudden increase, mother goes into sudden polyhydramnios at 32 weeks, it is acute. Acute means, again, it's in the terminology of time only. It is happening too fast, but too fast is in the term of, it's in the relation to the gestation age. So if it is happening before 24 weeks, it is just too early, and that is what is known as acute polyhydramnios. All right. Yeah, great. Thank you so much. Mostly from the notes, and that's why I said fairly recall based. Chaliye. Question. A 36-week pregnant lady came to the emergency department with complaints of difficulty breathing while she's lying down. She feels comfortable when she's in the sitting position or on moving to side. What is the likely cause in this scenario? 36 weeks. The baby is rather big at 36 weeks. And when she's lying down, she's feeling dyspnea or discomfort in breathing. So many questions on discomfort of, there was ovarian hyperstimulation and there was polyhydramnios. And now there is this one. So many things about, breathlessness in women. So good. Two were about pregnant women. One was about a non-pregnant woman on infertility treatment. Good. We are worried about women now. Good. They're asking about breathlessness in women. Great. Okay. So this is fairly simple IVC compression because in these choices, it cannot be anything else. Mother is lying down, the large baby compresses on the IVC, the venous return to the heart reduces, and that can cause discomfort because the lesser cardiac output. It can cause fetal problems. So IVC compression can cause these presentations. Fairly simple question. I think you all know about the advice that when a woman is pregnant, she should be lying down on the left or the right lateral position, left or the right lateral position. Okay, left is preferable, but yes, left also or right also, both are fine. Left is preferable. Okay, a 17-year-old girl with primary amenorrhea. She has breast development but absence. Now, this question, some 2-3 boys who were in touch with me on my WhatsApp, they were telling me some contradictory information. So, Krishna, my good friend, please tell me what were the choices. Then I'll give you the best answer. Okay, a 17-year-old girl with primary amenorrhea, breast is present, absent pubic and axillary hair. Bilateral inguinal masses are felt. On examination, there is absence of uterus and fallopian tubes and ovaries. Ovaries are absent. Yes. So ovaries are absent, then PCOS, Turner syndrome is already gone. With that one information, even hypergonadotropic hypogonadism is gone. Because, it can be in a man also this, but 2 choices are anyway gone if there are no ovaries. Because Turner syndrome has ovaries which are streaked, PCOS has ovaries which are slightly bigger. Okay, so these 2 are gone. So what were the choices, guys? This correct recall, somebody's saying. Sarcastic is being very pleasant to me, at least. Thank you so much. Right, guys, this is a straightforward question that it is androgen insensitivity syndrome. But one student who wrote to me, he said, sir, pubic hair were present and they were proper pubic hair. So if there is proper pubic hair, then what can be the answer? That's why it becomes a little confusing, because all of this is leading, bilateral inguinal masses. The meaning of bilateral inguinal masses is that there is undescended testes in a case of testicular feminization syndrome. It's looking like a girl, but bilateral undescended testes is classical. They might be mostly in the abdomen, but they can be inguinal masses also. So I feel that this was a slightly easy question if this was the information, but if the pubic hair are present and then there is absence of uterus tubes, then you'll have to mark hypogonadotropic hypogonadism, but the information is not adequate. It cannot be pieces in Turner syndrome. No, I won't say Turner syndrome, because breast development is not classical of Turner syndrome, and inguinal mass is why in Turner syndrome. So there's a whole lot of contradictory information. If we say pubic hair is present and rest all is the same, then none of these choices is the right answer. So yes, going by what information I have here, please go ahead and mark complete androgen insensitivity syndrome or a testicular feminization syndrome. Even in the recall, in the recall we discussed with you, not in the recall, in the revision before the exams, I told you about testicular feminization syndrome, and I quickly taught you in that 101 liner that it is a condition where it's a man who is born like a girl, and there's so much of estrogens that this man actually does not know that this is a man. He's a man. He is born and brought up like a girl, and this person grows up to be a very pretty girl. So that's why testicular feminization syndrome, a very pretty girl, but in fact is a man. They're tall and they're a little broad-shouldered, and they're very beautiful women. Quite a few of the models in the fashion industry, quite a few models. I mean, yes, I could be wrong here, but this is the talk between gynecologists, at least, that quite a few of these models are actually men. They are very pretty, they are tall, and they are broad-shouldered, and they have good femininity. So they turn out to be models, these testicular feminization patients. Oh, so much of chat has happened, is it? Clearly mentioned in a single line. Oh, it was not so big, is it? Okay. Mustaf Ahmed, breast development was absent. If breast development was absent, some pubic hair was there. So if that is there, okay, Mustaf Ahmed, I'm giving him credit. If he says breast is absent, some pubic hair is there, and absence of uterus, then it'll go in favor of Turner syndrome. If they say high FSH and LH, then I would say hypergonadotropic hypogonadism, but that information is not there. So breast was absent, but again, Mustaf Ahmed, why will there be bilateral inguinal masses? So who is telling me about this bilateral inguinal masses? Mustafi, was there, Mustafi, was there bilateral inguinal masses? Yes or no? At least tell me that. KK, nothing is present but inguinal masses. What is your diagnosis? I know, it sounded funny for a second. Okay. Breast is absent, breast is absent. Pubic hair is also absent. Goku, whose name you asking me? I forgot. I lost the chain of my thought. What I was saying, Goku, for which you asked me the name. So now a lot of you are saying that it was a case of bilateral inguinal masses, absent breast, and absent uterus, fallopian tubes, and absent ovaries. Why the inguinal masses? So what happens that it could still be testicular feminization syndrome. Why? Because breast development should happen. Breast is generally a little large. But if the breast development is not there, a lot of people don't have that breast development and they still might be testicular feminization. So testicular feminization characteristic is that there is absence of pubic hair. So there is absence of pubic hair and there is absence of breast and all the other things are the same. I'll still say androgen insensitivity syndrome. Okay, so upfront, it does look like a case of, because of that bilateral inguinal mass, it does look like a case of androgen insensitivity and testicular feminization syndrome. It's the same. You know, androgen insensitivity is of 5 types, 5 varieties of androgen insensitivity is there. And the type 5, the most severe androgen insensitivity is known to be the testicular feminization syndrome. Okay. Goku is asking me the celebrities. You want to get me killed? Okay, do one thing. Fine. This much is allowed, right? Goku, just put testicular feminization syndrome on Google and put images. I mean, go to Google, put testicular feminization syndrome and search the images. Some faces will come. That's all. I'm not saying any names. Okay. And whatever they say, nobody is actually pointing out the name of the famous people, the famous, Western people and the models, because nobody knows it for sure. So a lot of chat goes on Google, a lot of chat goes on and not all of it is correct. So I'm just saying that every time I do a search of TFS, and especially the images of these people, they're all very pretty people, but some, famous people also come there. And if you find a famous face, remember, I didn't name the face. So it could be anybody. Okay. Okay, चलो आगे चलते हैं. A 40-year-old woman was scheduled for a total laparoscopic hysterectomy. She was concerned about the procedure and inquiries the gynecologist. She was concerned about the procedure and inquires the gynecologist about laparoscopic hysterectomy. Which is the advantage of total laparoscopic hysterectomy? So when you do a laparoscopic hysterectomy versus a open hysterectomy, so open hysterectomy requires a lot of surgical. The time of surgery can be almost the same. Laparoscopic procedure known to be slightly longer, but good laparoscopic surgeons, like I regularly do laparoscopic hysterectomies. So I feel, yes, the time is still not as fast as open, but open requires a lot of suturing. So if you are a confident open surgeon, you can be a good laparoscopic surgeon at the same time. And don't do any laparoscopic surgery. All you surgeons and gynecologists here, don't do laparoscopic surgery till you spend some time doing SR-ship in surgery and gynae. Okay. Now, when you do laparoscopic surgeries, the bleeding may be the same. Bleeding may be the same in laparoscopy and in open surgery. But the timing of recovery and the hospital stay and the cosmetic is definitely better with laparoscopic procedures. So what is the disadvantage of total laparoscopic hysterectomy? So what have you guys answered? Wrong question again. Option D is wrong. What is option D? Option D was difficulty in observing electrosurgical burns. Yes, that is a major. If that was okay, delayed electrosurgical burns was given. You are saying difficulty in observing electrosurgical burns. Yes, that is correct. I would go with that. Because what happens in laparoscopic procedures, like I was doing just around, I told you half an hour back. So when you're inside the abdomen, suppose you're inside the abdomen like this, and let's say you have to go and burn this ligament here. You have to burn this ligament. And you're not very careful. See, you're not very careful. You have to burn this ligament. What happened? It's a little blurred. Yeah. You're trying to burn this one area with your instrument. When you're trying, suppose this is a cautery. My pen is like a cautery I'm showing you. You're trying to burn this area. But some part of this cautery is naked somewhere and it causes a burn in organ which is somewhere here. You're burning this organ here, but the burn is because of a part of this cautery is open. So it can cause burn and you don't realize it. You are burning this area and the heat is so much that some current jumps and burns the bowel next to that organ and you don't realize. It jumps and you can't see it jumping. So yes, okay, conductance, capacitance, there's so many types of laparoscopy injuries which can happen by the cauteries. And you will not be probably able to recognize if you're doing a very long surgery and you're tired and you had to do laparoscopic procedure, you may miss these. So yes, if somebody's saying that difficulty in observing, then I would definitely say delayed identification of burn marks. Yes, I would go with that. Delayed identification of electrosurgical burns, yes. Difficulty in identifying electrosurgical burns, yes, correct. That is a good choice. All right, yeah, that was the. Then, of course, if this is there, then difficult observation, I would go with that answer. So let's change this. Difficult observation. Difficult observation of electrosurgical burns. I would go with this, yes. Okay, so the next question, a 53-year-old patient diagnosed with cervical cancer. On examination, necrotizing lesion on the cervix was extending to the parametrium. What is the management of this stage? Guys, I told you that see a cervix and see endometrium. Whatever happens, you have to know the staging. And those who have ever done my class would have remembered that I said see a cervix, you should know like the back of your hand, and just like see a breast. Because see a breast is the most common malignancy of women in our country, and see cervix is the most common genital malignancy of women, and by sheer number, forget genital and others. Most common cancer, see a breast. Second most common is see a cervix in women in our country. Please read these two properly and the staging properly. Now, when there is involvement of the parametrium, 2B is parametrium and 3B is parametrium. So parametrial involvement. Suppose there's a cancer here, which is in the uterus. Now it is involving the vagina. I've changed the color. Now it is involving the parametrium. This is the parametrium. So when the parametrium is involved, so 2B, 2A. 2A is upper vagina. 2B is parametrium, but not to side wall. Side wall is not involved. And 3A is lower 1/3 vagina, and 3B is parametrium till side wall of pelvis. So this is why 2A and 2B are different. 3A and 3B are different. See, 2A is vagina, 3A is vagina. 2A is upper vagina, 3A is lower 1/3 vagina. 2B is parametrium, 3B is parametrium. 2B is parametrium till the wall, 2B is parametrium involvement, and 3B is parametrium till the pelvic side wall. So you must remember the way I'm trying to teach you. Okay, I give you color codings of this staging when I teach you in the class. So 2A upper vagina, 3A lower vagina, 2B parametrium, 3B parametrium to the wall. So when they ask you about treatment of CS cervix, all of us remember that the treatment of CS cervix, we say from stage 1 to 2A1, we do a radical hysterectomy. Okay, type 2 is radical, type 3 is radical, type 2 hysterectomy is Wertheim's, type 3 is Meeks, both are radical. We do more Wertheim's in our country. Meeks is a favorite American radical hysterectomy. Now, from beyond 2A2, from 2A2 onwards, we give chemotherapy and radiotherapy, chemoradiation. Now, this is the MCQ which is coming in different ways in all your exam. And I think that is what they're trying to ask you here. A 53-year-old patient diagnosed with CS cervix on examination, necrotizing lesion of cervix was extended to the parametrium. That means it is 2B. They have not said it's going to the wall. So it is 2B. What is the management of this stage? So anything beyond 2A2 is chemoradiation. So is there chemoradiation here? Chemotherapy, surgery, biopsy, surgery plus radiotherapy. So chemo radiation was not an option also. Don't tell me, it's breaking my heart. Chemo radiation was there or not? Prince Samuel is saying there is chemo radiation. So Prince, are you sure? Goku sir, I thought I was... Chemoradiation was, see, necrotizing, you should not get confused, Goku, because necrotizing is whenever there is a lesion in the cervix, it can get necrosed very easily. It is fungating, necrotizing, stinking. See, a cervix can be so many things. So, foul smelling discharge is so much common. Necrosis is there because the tissues are going on proliferating and they get necrosed and keep sloughing off. So, don't get too upset by this necrotizing. Chemoradiation was there, okay? It was there, okay? It was there. So I am very happy it is there. Please, chemoradiation is something which is going to come in all your exams. Please don't miss out on CS cervix, okay? Sorry, good. I'm happy you said that. A 25-year-old lady who was sexually active with multiple partners, presents with swelling in the wall of the labia majora. What is the most likely diagnosis? So please remember, yet in my practice, I'm working in gynae. I mean, I started my PG in 1996. Now it's a whole lot of years. It's 26, 27 years of being a gynecologist. And how many Bartholins I've taken out and how many abscesses I've drained, I have no idea. I've done excisions, I've done drained abscess. I have yet to see a Bartholin abscess in a lady who is not sexually active. So this is not to say anything. There are exceptions to what I'm trying to say, but I've yet to see it without a person who is not active. So there is some talk that it can happen, but you can ask any gynecologist and he'll also say that nobody sees a Bartholin abscess. So sexual activity, Bartholin is required for the lubrication, and if it gets blocked, then that blocked gland will make a Bartholin cyst. If it gets infected, it will make a Bartholin abscess. So yes, this is definitely a Bartholin abscess. And the history which they were trying to give is relating to what I'm trying to tell you, that sexually active women mostly have a Bartholin cyst or an abscess. Okay? Chalo. What was your Bartholin or fine? Bartholin cyst. Okay. Right. So, yes, those are the MCQs which I have with me. But if you have something which you can ask me, there was something about the kits, and I saw somebody writing, but I think the kits are generally taken by your PSM doctors, and I'm sure they told you about that. If there's anything, you can ask me also. It's all right. I always give you an email. And recently, I've seen that you have started writing to me. So I'm trying to answer all of you guys. Dr. Prassan at yahoo.com. I'm definitely available on the PrepLadder forum. When I come on the PrepLadder forum, there are just too many questions sometimes. So around 4 days back, I finished all of them. So if there are more questions, I'll be seeing on the PrepLadder forum always. Otherwise, Dr. Prassan at yahoo.com is where I'm available for you guys. You can always get back to me. Anything else you want to ask me? Partograph. What was there in Partograph? Oh, I want to know what is there in Partograph. Was it 4 centimeter, 5 centimeter? Was it something like that? Because WHO is saying 5 centimeters and Americans are saying 6 centimeters, but all our partograms are at 4 centimeters still. So for me, it is still 4 centimeters. If any medical college changes it, I'll tell you to change. But yes, we are talking about it. All of us obstetricians are talking about 5 centimeters, and we actually don't start troubling a woman till good 6 centimeters practically. But what is in the book, what is in the partogram of the country is still 4 centimeters. So if there's a recommendation by WHO, we don't implement it immediately. We talk about it. Once all the medical colleges implemented, then I'll tell you. Obstructed labor. Answer was immediate cesarean. Okay, fine. Obstructed labor, the dilatation is straight and the descent is straight, or it is not, the two curves are not merging and not crossing. It is taking time. It is obstruction. Fine. I think if some questions cannot be recalled, isn't it? Obstructed labor on partogram. All right, fine. PrepLadder team, there's a question on obstructed labor in partogram. Please remember to discuss this whenever we're making this video. All right, guys. If that is the only one, I think let's move on. Obstetric labor management, Gangani, Dr. Gangani, obstructed labor management is indeed cesarean section. So if you see the partogram, she's saying, if you can explain me a little bit, yes, if you see a partogram like this, and the station like -5 to -4, -3, -2, -1, 0 plus 1 plus 2 plus 3 plus 4 plus 5. This is the station. And the dilatation is also in the same graph. So it is from 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So when we're talking about this, the patient is in active labor at 4. So the cervical dilatation, I'm saying, should go like this, and the station should come like this. Oh, I'll take another color. So station should come like this. So, we see it in time. The time graph is here. Suppose we see at 4 p.m., 6 p.m., 8 p.m., 10 p.m., 12 midnight, 2, 4, 6, like that. So when we are doing this, so it should go on coming down. See, station is here, it is here. So we mark it by a 0. Station is marked by a 0 here and here. So this is how you mark a station. And the dilatation is marked by a cross. So it's here, and it's, sorry, we'll use the color differently. Here, 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 and here. So it is now 10 centimeters here, and it is plus 5 here. Like that, when it goes down, the dilatation is going up and the station is coming down, and they cross before the 4 hours later, we have the alert line, and 2 hours of that is the action line. So this is the alert line, and this is the action line. So this is what is normal. Now, I'm sure that in your graph, there would have been something like the station is staying straight. It is gone beyond this. It is like this, like this, like this. And the dilatation is also going almost straight, like this, like this, like this. So if it is going beyond the alert and beyond the action, and the contraction shown in the graph are good, then it is obstructed labor. So something like this, I'm sure this is very cryptic. I've made it. Something like this, it should happen. So oh, you're asking CA cervix stage 2, and I explained you everything about partogram. So what do you want me to see about CA cervix stage 2? CA cervix stage 2 is 2A and 2B. 2A is upper vagina, and upper vagina has A1 and A2. So till 2A1, we can do radical hysterectomy. Beyond 2A2, because it becomes more than 4 centimeters. More than 4 centimeters, surgery will never be effective. There's another stage which is cancer is limited to the cervix, B1, B2, B3. B3 also, although I said till 2A1, I can do radical hysterectomy. But if it is B3, it is 4 centimeters again and more. There also, we cannot do surgery. Anything which is more than 4, we do surgery, because it's difficult resection and it is unlikely to give us the best clearance. So by law, we say till 2A1, surgery, 2A2 and beyond, chemoradiation. So that's what is there about stage 2. It hadn't crossed the action line. It had crossed the alert line. That's enough. Why wait till the action line? When it is not descending and when it is not dilating every year. See, basic rule is, thumb rule is, every hour 1 centimeter. In active labor, every hour 1 centimeter dilatation and 1 centimeter descent. That is the thumb rule. If that is not happening for 3-4 hours, why wait till the action line? In alert line itself, why wait till action? Okay, it's not required that you must wait till action. You are a good obstetrician, you should be able to diagnose obstruction much before. Why wait for obstructed labor to have happened, and then you do a cesarean and then end up with a vesicovaginal fistula because of obstructed labor? Head was not engaging. Fine. If the head is not engaging, the dilatation won't happen and the descent won't happen. So that's fine. Fair enough. So I think that's more than enough for discussion today, guys. I think I was supposed to take a short discussion, but then, as usual, I keep on discussing so many things with the questions and related stuff. And I hope it is useful, whenever you are having a discussion with us. And all of this does come, all these clinical scenarios only. I mean, I remember discussing quite a few of this in the last 3 sessions, the images with OBS, images with gynae, and the 100 one-liners, which we did before the NEET exam. I think most of these things were discussed in that time. So forget reading the notes, just this discussion would have helped you to solve your questions. So anything else, you can get back to me on my email or on the PrepLadder forum. And I hope all of you do very well and get the seats which you want. Parting statement, as always, you get DNB, you get MD, you get whatever. If it is your second attempt, just go ahead and grab it. Always I say, first attempt, get what you like. Second attempt, like what you get. That is happiness. All right, settle down fast, guys. God bless you.